can get that to go. There we go. Is a review of weight gain, maybe. Can't get that little box to go away. There we go. A review of weight gain with the selective serotonin reuptake inhibitors. So looking at the whole class of SSRIs. From an objective standpoint, we're going to identify the prevalence of weight gain with the SSRIs. I'm going to talk about both the weight gain and the weight loss, as well as some of the changes in appetite. We are going to compare those numbers between the 6 different medications in the SSRI class, and then we'll very briefly describe what may be behind us seeing some of these weight gain changes with the SSRIs. I will spoil that last objective. We have no idea. We have no idea. It tends to move in the opposite direction. So this is still up for investigation. So if you're holding out on that one, I don't want you to be disappointed. All right, I wasn't really sure where to start with this particular presentation. So I started with antidepressant use. So how frequently is it that we're seeing the SSRIs? So in the United States, this data is taken by the CDC in the National Health and Nutrition Examination Survey. This was the survey data that was published in 2020. Antidepressants are very, very commonly prescribed. They looked at a snapshot of usage of antidepressants between 2015 and 2018. So the question that was asked to adults, so those individuals who are 18 years or older, was how are you using an antidepressant in the past 30 days? So what they found was that there were quite a few individuals that were using antidepressants. So the overall prevalence was 13% for all adults. It did have a gender difference. So the blue bar are just everyone who is 18 years and older. So there were 17%, almost 18% of the women, and just over 8% for the men. But when they broke it down based on age, they also saw a trend with increasing use with increasing age. So for individuals who were 18 to 39, the overall prevalence was about 8%. Again, females had more use of antidepressant than males at 10% versus 5.5%. When they looked at 40 to 59-year-olds, so a little bit older adults, I guess more middle-aged adults, I don't want to be called older because I fall in that category, it was about 14%. And again, female versus male, this was really a pretty significant difference between the two genders here, with 20% females and 8% of males. And then when they looked at those who were 60 years and older, there was an increase to 19% with 24% of women. So the most frequently prescribed demographic was women who were over the age of 60. But as they looked at all of the years, 2015, 16, 17, and 18, they saw a trend of increased antidepressant use compared to 2015. There were some ethnicity differences. I would imagine most people are not going to be surprised that non-Hispanic white adults were prescribed much more frequently than those who were non-Hispanic Black, those that were Hispanic, and significantly more frequently than those who were Asian. We mentioned that the highest use was in that older demographic, and there was an education difference that they noted as well, with those who had at least some college education being more likely to be prescribed antidepressants compared to those that had either a high school education or had not finished high school. So relatively frequently being used. Now this was a catch-all, so this was all antidepressants. We're focused today on the SSRIs. So for those selective serotonin reuptake inhibitors, they were among the most commonly prescribed antidepressants. This trend has held true since at least the mid-1990s. It looks to be just over 60% of antidepressant prescriptions are in the class of the SSRIs. So we're increasing the use of this class, and of this class, these are the medications that are most commonly utilized. And they're used for a whole bunch of different reasons. So I do want to point this out just because we see a little bit of a difference in the changes in weight based on the indication that we're using. So this chart is just kind of a reminder. It's also a teaser for the P3 students who are here, because you'll see this starting in neuropsych, which starts next week. These are the official FDA approved indications of the 6 SSRIs we're going to focus on today. So eating disorder wise, it could be used. It's used off label for anorexia and binge eating, but a lot of anxiety disorders, as well as mood disorders, so major depressive disorder. We see a little bit of other things in terms of menopause and postmenstrual dysphoric disorder. There was not much data that looked specifically at weight gain in these 2 populations, so I included it for completeness, but that's really not going to be what most of this data is based off of. Okay, so I think that laid the foundation. We're using these a whole bunch and we can use it for a lot of different things. So how much has weight changes been identified as an issue? I had a little bit of trouble finding this information. So I went to a few different sources. So I did use some of the tertiary resources, things like Lexicomp and Micromedics, just to look up what does it say that the frequency is. Then I went to the package insert for every single one of these to be able to see what are the percentages that are listed. What I'll tell you is there's not a ton of information. So in terms of weight gain, this was not identified in most of the package insert trials. Why? I'll spoil this as well. In the short term, we see weight loss. So this really wasn't identified in the initial list of adverse effects for the SSRIs. The increase in appetite also was very rarely reported in those. Some of the prescribing information that have been updated with post-marketing data does include some information about it, but it does tend to be relatively limited. What's most frequently reported in both the tertiary resources, so kind of those general drug databases, as well as the package, the prescribing information, is weight loss and decreased appetite, which is called a few different things. In some cases, they called it anorexia. In some cases, they did call it decreased appetite. There was one other term and it escapes me right now, but I'll think of it. But those were pretty frequently reported. They tended to occur at a frequency greater than placebo, but it was not one of the reasons that individuals ended up discontinuing therapy. So it really was something that was present, as you can see, for some of these agents, fluoxetine, fluvoxamine, and paroxetine, these 3 in the middle, over 10% were reporting that there was a decreased appetite from baseline, but the patients were pretty okay with that occurring. To be fair, in those acute trials, so that is 12 weeks or less, in the first couple weeks of treatment, it's very, very common for patients to experience nausea, vomiting, diarrhea. They may have some dyspepsia or feel like there's an upset stomach. So that may be contributing to why we see some of those higher numbers here in terms of decreased appetite. There was weight loss that was reported. I thought the sertraline data was a little funny. The best I could find was a slight increase in terms of these tertiary databases for adults, but they did see it in children. So I did just want to point that out, that they saw some weight loss there, which is the highest percentage that we had from any of the agents. So it looks like we have a little bit of a muddled picture. So can we get some type of clarity on this? Is the weight going up or is the weight going down? There are a couple confounders that I do want to point out as I was looking for evidence related to this. It's not easy. This is not something that's pretty straightforward to be able to get the data on. Some of the confounders that they point out, it's unclear on what the baseline lifestyle is for the patients. It's very possible that what their expectations are in terms of dietary intake or physical activity are such that they would continue to gain weight over time, even long term. It's estimated that the average adult in the United States gains about the average is about 3 pounds a year. There is quite a bit of variability there, but that is an increase over time, year by year. The symptoms of anxiety and depression, now I had pointed that out previously, actually could have some changes in appetite and weight. So anxiety may diminish appetite. Appetite changes are one of the diagnostic criteria for major depressive disorder. So it's very possible that the changes that we see in appetite and weight may be due to the condition itself, as opposed to being due to the medications. And this is one of the probably most significant confounders, because we don't have enough data now, which is why I pointed out the premenstrual dysphoric disorder and menopause would have been fabulous to help us clear this up, but we were unable to get that significant amounts of that data, at least at this point. So if patients are improving their depression, it's possible that their appetite had diminished, their weight had gone down. So as their symptoms resolve, we see an increase back to what their baseline had been, which on paper looks like an increase in weight, but maybe that's not a bad thing. Maybe that's keeping them within the normal range for their body mass index. Which brings us to the last confounder. Quite a few of these the clinical trials do report weight changes, but based on changes in kilograms. They don't necessarily do it based on changes in BMI. More of the recent trials are including some of that data, but there's a pretty big range in terms of normal or healthy BMI. So it's possible that somebody stays within the same category, but we do see pretty clinically significant changes in their weight. You could have a weight change of 5 to 10 pounds, and that would result in a patient potentially needing to get all new clothes, a whole new wardrobe. So that could have a pretty significant impact on them. So none of what I'm going to show you is going to help with these confounders, but hopefully it'll help explain why the data that we have is kind of fuzzy. All right, so what is the data that we have? One of the best trials that we have to take a look at this was a trial that was done with just fluoxetine. So these investigators took adults who had major depressive disorder. Now they really had to have about moderate major depressive disorder. They couldn't have a number of other medical conditions or any other type of mental health condition. The individuals were then given fluoxetine 20 milligrams daily, and they were able to reduce the dose if they couldn't tolerate that dose, and they were treated in an open label fashion for 12 weeks. All of the individuals in that cohort who achieved remission, so their depression rating scale score had fallen to a level where there were minimal to no symptoms still present, were then re-randomized. So they were re-randomized to either fluoxetine 20 milligrams or placebo. So one of those two interventions, but then they were given it for a different duration of time. So one group took fluoxetine or placebo for an additional 14 weeks in a double-blinded fashion. A different group took either fluoxetine or placebo for 38 weeks in a double-blinded fashion. And the last cohort took fluoxetine or placebo, and they used it for an additional 50 weeks. So they were really trying to look at what is the change over time if we continue with the fluoxetine. So the results are in the chart that I have on the right-hand side here. So 73 kilograms, 73.7 kilograms was the weight at baseline. They all had improved. So all of the patients who achieved remission had a change to 73.2. So there really wasn't a huge alteration or reduction in weight over those 12 weeks. It was small, 0.5 kilograms, so about a pound. So not really a significant change that we saw at that 12-week mark. Once we randomized to those different durations of time, they did not give us what the mean weight was for each of the cohorts. That would have been nice to know, but that wasn't what they ended up giving us. What they did give us was what is the change in weight. So how much did their weight change compared to the end of that 12 weeks for each of the cohorts? And then what percentage of those patients had a weight increase of more than 7%. So a change of weight of more than 7% is thought to be clinically significant. It's meant that really is a pretty significant increase in weight. So for those that were treated in this shortest group, so 14 weeks, they did 26 weeks total. They had an increase in weight of 1.1 kilograms. So just like 2, 3, 4 pounds. Those that were treated in the next group had an increase of 2.2 kilograms. So they gained about 5 pounds. And those that were treated for the 50 weeks actually had a 3 kilogram increase. So we did see it increase with the longer the duration of time that patients were on the fluoxetine. When we look at those that had that really significant increase in weight, it was about 5% for the group that was treated just for the additional 14 weeks, 10% for those that were treated for the 38 weeks, and 13% for those treated for the 50 weeks. So again, we did see an increase. Now, these were not different from placebo. They also had groups that increased, but what they're looking at is there is a weight increase over time with the continued use of fluoxetine. So is there any way to look at more than just fluoxetine, or to gain even more clarity of, is this weight gain something that happens because of the disease state or because of the medications? Oh, and I'm sorry, I forgot I had included that. Whoops. So this was about all of the data that they gave us. So this is the change from baseline weight on the y-axis. So these first 12 weeks, the blue boxes, everybody was in that. That was the open label 12 weeks. And then they were split into their various groups. And as you can see, the placebo group started gaining weight pretty quickly, whereas the paroxetine group gained weight at a slightly slower rate, but they really ended up being not different. So both gained weight after they had achieved remission. So now let's see if we can have some data on some of the other SSRIs. So this was a trial that was done also in adults with major depressive disorder. Everybody was given a 1-week lead-in of placebo. So they wanted to make sure that they didn't respond to placebo, that their depression was pretty moderate. They then were randomized to either an antidepressant or to placebo. So they could have gotten placebo and then fluoxetine, sertraline, or paroxetine. They were able to titrate to maximum doses if tolerated and necessary, and they were treated for a minimum of 26 weeks or a maximum of 32 weeks. They, again, did not give us the total weights, those mean weights, but they did look at mean change from baseline. So for at least 26 weeks, what did we see? Well, the fluoxetine group had a mean reduction of 0.2%. So maybe a small decrease in what their weight was compared to baseline. The sertraline group had a 1% increase in their weight. So their weights at baseline were about 77 kilograms. So possibly we can estimate that. Is it going to be clinically significant? Maybe for some, but probably not for most of them. And then we saw a 3.6% increase with the paroxetine. The paroxetine group was the only group that was different from placebo. Neither the sertraline or the fluoxetine group differed in the mean change from baseline. When they looked at those that had so this was the percentage of patients that gained more than 7% of their body weight over this 26 to 32 weeks, we see that about a quarter of the patients treated with paroxetine gained more than that 7%. About 7% of the fluoxetine group, which I'll be honest, surprised me because the mean change from baseline was negative, that they lost weight. So it seems like there was a small subset that did gain a pretty significant amount of weight with fluoxetine. And then about 4% of the sertraline group, which numerically seems to make sense. So even though the mean change from baseline doesn't look like it was too much, there is a group of patients that are gaining a clinically significant amount. And this makes paroxetine look by far the highest risk agent. So there are quite a few clinical trials that exist. I was able to find a systematic review and meta-analysis that pooled a lot of the data. It pooled a lot of the anxiety and depression trials to look at what is the true impact on weight, both short-term and long-term, for the SSRIs. So this is our list of SSRIs. These are the number of patients that were actually taking the medication. The control are the number of patients that were taking placebo. Overall, in the 4 to 12 weeks, so that acute short-term treatment, we saw weight loss pretty much across the board, with the exception of fluvoxamine, which tends to be used only for patients with obsessive compulsive disorder. So they all lost weight compared to placebo, and lost weight compared to baseline as well. So again, kind of what we would expect. We have some of those gastrointestinal adverse effects initially, which may help contribute to this. Long term, are we seeing the same thing? Interestingly, most of them did not differ from placebo. So again, the medications, we did not have fluvoxamine long-term data, so that's why it's missing here. Case are the number of patients who are taking the drug, control are the number of patients who are in the placebo group. And we see that for citalopram, escitalopram, and paroxetine, we did see an increase in their weight compared to baseline. So it looks like they had gained weight. But those numbers that are in parentheses are the confidence interval. So that's kind of the range that they could fall in, because this is an average. So most of them were not significant. Fluoxetine and sertraline still look to have a little bit of a loss, but only the paroxetine group was the one that looked to have a significant amount of weight gain compared to placebo and compared to baseline long-term. Interestingly, when we look at, so they pooled all of the data in this figure 1 that's here at the bottom. And when they did that, paroxetine crosses 0 in terms of the estimation of weight change, so what we would expect. But it looks much cleaner than some of our older antidepressants, things like the amitriptyline. So yes, it looks like there is some additional activity there. Paroxetine's the only SSRI that has anticholinergic activity, which is activity that the tricyclics, things like amitriptyline, also have. So maybe it's that little extra action that might be starting to make it trend in that direction. So why might this happen? I promised that I would mention this. We don't know. We're not exactly sure. Serotonin is clearly a modulator of food intake, of body weight, as well as of energy metabolism. It's involved in a number of different pathways. It innervates a number of other neurotransmitters, dopamine, glutamate, some of the pathways that release some of the hormones. There is extensive research ongoing looking at the serotonin receptors that are present in the pancreas in its potential role in diabetes. So it looks to be intricately involved in a number of different steps in the metabolism process, not all of which are incredibly clear at this time. Overall, it appears that there is an inverse relationship. So increased serotonin tends to result in decreased food intake, specifically decreased carbohydrates. So in most cases, in some of our obesity treatments, that's what they're focused on. So they're really focused on increasing serotonin to reduce weight because it's reducing craving for food. It seems to uncouple food from the reward pathway. So it looks like it could be beneficial there. But some of the peripheral serotonin receptors look to be involved in promotion of energy absorption and storage, which means turning the calories that you eat into fat, which would move the weight in the opposite direction. So it looks like there's a lot more involved than just saying serotonin can decrease food intake. When we look specifically at our serotonin receptors, the 2C receptor has the best data. So activating the serotonin 2C receptor is associated with satiety, patients feeling full. It's associated with decreased food intake and specifically decreased carbohydrate ingestion. So activation of that receptor, again, as in some of our weight loss medications, that seems to reduce weight. But our SSRIs just increase serotonin across the board. And we have actions at the 1A receptor, the 2A receptor, and the 3A receptor that are associated with increases in food intake. So it's unclear in each patient which side would win out in terms of we're going to decrease our food intake or we're going to increase our food intake. The other potential wild card is by overall increasing the amount of serotonin that's present, there is the possibility that some of the receptors, like the 2C receptor, are downregulated. So the body sees activity at these receptors and says, we have way too much action here. We got to get rid of some of these receptors, and it would reduce the size of that signal. So that may potentially play a role as well. So more to come. This is definitely an area that's exploding in terms of research. So if we encounter a patient who has gained weight and are on an SSRI, lifestyle modifications are definitely recommended. Trying to increase any type of physical activity and at least be more mindful and potentially more selective in some of the food choices. There was one open label trial. It was 10 weeks long with the use of topiramate, and they used low dose topiramate, so 50 milligrams of topiramate with the SSRI, and they did see a reduction. So these patients had gained almost 30 pounds on SSRIs compared to baseline. And when they were on the topiramate, they actually lost about an average of 10 pounds. So maybe adding a medication, because we don't always want to treat a medication side effect with another medication. Another option may be switching the antidepressant. Bupropion does have the best data, but only when switching depression patients. There's not a lot of evidence at this point for switching a patient on an anti-anxiety medication to something that's a lower weight risk medication, because bupropion doesn't have a ton of data to support its use for anxiety disorders. So not a lot that was out there. And actually, this was pretty dated. So I was surprised that we don't have more information, but I think it's definitely being looked at in the research realm. So my guess is we will start seeing some new recommendations in terms of what we can do for those folks. So to wrap up, serotonin definitely plays a significant role in appetite, metabolism, and weight. Weight changes are reported with SSRIs. Short term, we see a reduction pretty much across the board. Long term, it's a little bit more unclear. There looks to be subsets of patients that gain a significant amount of weight, but it's unclear if it's due to the medication itself or due to the disease. Although the signal suggests that maybe paroxetine might be a likely causative factor for some of that weight gain. So that's what I've got.